Welcome to the second session of MBios Research Insider. My name is Ziman and I'll be the host for today. Just a little housekeeping before we get started. As you know, we are also broadcasting live on Facebook as well. So do share the live stream with your family and friends who are interested to join us today. If you have any questions during the session, feel free to type into the chat box or raise your questions during the Q&A session later after the sharing session. Now, I would like to introduce our speaker for today, Mr. Yong Quan Lee. Yong Quan completed his bachelor's degree in genetics at the University of Edinburgh in 2019. He then worked in Cancer Research Malaysia as a trainee genetic counsellor and research assistant in the Genetic Counselling Unit, where he was involved in both clinical and research work relating to genetic testing for cancer patients and their family members. He has experience working with different stakeholders, including clinicians, researchers, and pharmaceutical companies to improve access to genetic counseling and genetic testing for breast and ovarian cancer patients across Malaysia. Yong Quan's interest lies in clinical genetics and patients' communication. He aspires to become a certified genetic counselor and is now in the process of completing his postgraduate training in genetic counselling at the University of Melbourne, where he is due to graduate in December 2023. So without further ado, I'll return the time to Yong Quan. Now, Yong Quan, the floor is yours.
So thank you for the kind introduction, and thank you to the MBios committee as well for having me today. So good morning, good afternoon, good evening, everyone, depending on where you are. So as mentioned, my name is Yong Quan, and I am a final year Master of Genetic Counselling student at the University of Melbourne. And hopefully by the end of today's session, you'll be able to walk away knowing a little bit more about what genetic counseling is. So this is an overview of what we'll be talking about today, starting off with a very quick recap on some basic genetic concepts, and then we'll spend some time talking about what genetic counseling is in a clinical setting, but also some of the evolving roles of a genetic counselor outside of clinic. And then finally, we'll talk about the career prospects, some key things to consider or take note if you do intend to apply for a master's in genetic counseling program, and just very quickly about certification as well. Right, so I hope this slide doesn't trigger any bad memories for anyone, but to start off, I'm sure most of you in this audience would be aware that our genes or DNA are packaged in structures called chromosomes, and they are coded in four nucleotides or letters A, T, C, and G. And there are actually over 7,000 known genetic conditions in humans that arise because of genetic errors, which can happen either at the chromosome level. So for example, here you can see that this individual has an extra copy of chromosome 21, or what we call trisomy 21, which leads to Down syndrome. But there can also be deletions or duplications of a chromosome segment. But there can be mutations happening at the gene or nucleotide level. So here's just an example of a base substitution, insertion, and deletion. And there are many other types of genetic errors that we know of. So in genetic counseling, one of the things that we start off with is explaining these concepts to patients or families, because in order to understand what's going on in a person with the condition and how that will affect other family members, these concepts are pretty much fundamental. But I guess one thing I'd encourage people to think about is how do you explain these things to a layperson, or perhaps even someone with very limited health or genetic literacy, without throwing in all the medical jargons I've just used. And essentially that's the job of a genetic counselor, to dissect complex genetic information in a meaningful and understandable manner. And if you Google what genetic counseling is, you'll probably come across all sorts of different but fairly similar definitions. So one of the definitions that is widely used and cited is this one that's established by the National Society of Genetic Counselors in the US, which states that genetic counseling is the process of helping people understand and adapt to the medical, psychological, and familial implications of the genetic contributions to disease. And the reason why I've highlighted those three words there is because we don't just talk about the condition, we don't just talk about what the condition means for the individual clinically, but also what it means for other family members and future offspring as well. So oftentimes when we get a patient referred, we actually end up providing care for the entire family unit, particularly if the condition is found to be inherited. And I'll talk a bit more about that later. And genetic counselors are also trained in providing psychosocial support, because you can imagine the amount of emotional and psychological stress someone is going through after they find out about a genetic diagnosis, either in themselves or in a family member. So this entire process involves the interpretation of personal and family history, education about inheritance, testing options, clinical management, and other resources, as well as counseling. And this is just, I guess, a quick slide to show that, especially now, there are many different genetic counseling specialty areas. So the three most common ones are reproductive or prenatal genetic counseling, pediatrics and cancer, but other specialties such as cardiology and neurology have become pretty common in the past decade or so. And there are many others that are catching up as well, such as psychiatric genetic counseling, ophthalmology, immunology, and so on. And I guess this just demonstrates the increasing importance of the role of genomic medicine across all medical specialties. So I'm going to briefly talk you through what a typical genetic testing process is like. And I've put typical in quotation marks because every country and every clinic differs in practice. And the whole process from start to end really varies on case-by-case basis. But I suppose safe to say this is what usually happens in a traditional genetic counseling model. So once we get a patient referred to us, the first thing that we do is what we call a risk assessment, which basically means trying to work out whether there is a high, moderate, or low chance of the condition being hereditary in nature. And the primary way we do that is by collecting personal and family medical history. So in genetics, there are standardized ways of how we draw a family tree, or in medical terms, what we call a pedigree, as well as how we indicate certain information on a pedigree. And these are just some few common examples of the basic annotations that we commonly use. So for instance, squares indicate males, circles indicate females, and affected individuals are usually shaded in. And this is an example of how a pedigree would look like. And the arrow at the bottom left, I'm not sure if you can see, but there's an arrow at the bottom of it. So that arrow indicates a proband or the patient referred to us. So although I have to say this is probably not the best pedigree in terms of the required amount of information, because we always try to get a 3-generation pedigree. And at the very top, so for the grandparents' generation, we actually know nothing about their siblings. And we also always try to get both paternal and maternal family history with respect to the proband. So if we see here, I only know what's happening on the paternal side. I have no clue what's happening on the mother's side. But having said that, oftentimes it can be challenging for patients to recall or reach out to family members for this sort of information. So that's also something we need to acknowledge and keep in mind as well. Right, so after we have the family history, we also need to know what the mode of inheritance is in order to work out the reproductive risk or risk to other family members. And maybe these 3 terms here will ring a bell for some of you. I'm not going to go into the details, but essentially these are some examples of the possible modes of inheritance, but there are many others that we know of. And depending on what the mode of inheritance is, the risk assessment for that family would be slightly different. And I've also put a note at the bottom to say that not all genetic conditions are inherited. And obviously that's important to know as well, because risk assessment for family members would also be completely different if a condition is not inherited in nature. So here I have 2 case examples that we might come across in clinic. Again, don't worry about all the details on this slide. But if you look at the, I guess, bottom left, the circle with the green arrow, so that's a proband. You can see that the proband has had both ovarian and breast cancer within the same decade. So that is a red flag for an inherited cancer syndrome. And she also has a sister as well as a father who both had colon cancer at a relatively young age as well. So another red flag. And we can also see that there are multiple family members on the paternal side with different kinds of cancer, although not all of them might be related to the same inherited cancer syndrome. So I guess for those of you who are familiar with a bit of genetics, if I told you that most inherited cancer syndromes are inherited in an autosomal dominant fashion, a food for thought would be who else in the family do we offer testing and why if we do identify an inherited genetic change in the proband. Right. So this is the second example that has to do with a condition called Fragile X syndrome, which is the most common cause of inherited intellectual disability. And all of the other clinical features you see there in the legend are also commonly present in a Fragile X family. So again, if you look at the proband, you can see that he has what we call tremor ataxia syndrome, which are basically involuntary tremors or shaking of parts of the body. And both his siblings as well as his mother all have Fragile X associated features as well. And two of his cousins were actually diagnosed with Fragile X syndrome themselves. So that might give us a little starting point in terms of doing risk assessment. So that was just a quick whiz through risk assessment, but that's just one part of a story. So remember how I mentioned earlier about psychosocial counseling? That is also something that we put a lot of focus on during this session. And obviously every individual is different and will have different concerns. So these are just some of the common examples. And our aim here as genetic counselors is not to solve all of these problems. It'll be great if we can, but some things are just beyond our control as healthcare providers. However, what we aim to do is to understand what the patient's thoughts and values are towards genetic testing and what are some of their motivators and barriers that they're facing. And from there, not make a decision for them or on their behalf, but help them come to an informed decision themselves after weighing out all the different considerations together. And even if that means not wanting to proceed with a genetic test at the end of the day, that's okay. Because what we want is not the patient to walk out of the room with a genetic test, but for them to walk out of the room understanding its benefits and limitations, and for them to feel empowered to make their own healthcare decisions. And this slide is just to show that individuals who are at different stages in life will have very different concerns or views towards genetic testing or a genetic diagnosis. So for example, if I was counseling a first-time mom, the concerns would most likely be quite different compared to if I was counseling a 70-year-old man, for example, who has many children and grandchildren, versus if I was counseling a teenager who has an inherited cancer syndrome. So again, some food for thought. Right, and assuming that the patient does decide to go ahead with genetic testing, you don't just call up the lab and be like, hey, I'd like to have a genetic test, please and thank you. It's like going to Starbucks and telling the barista you want a coffee. You probably have to be more specific than that. So as a genetic counselor, it is also important for you to know what sort of test you're ordering, and that really depends on what information you want to find out. Is it to confirm a diagnosis? Are you testing the proband's family members? Or are you testing a couple who wants to have a baby? Or are you testing a couple who are already pregnant? So these are all important questions to ask yourself. And there is no such thing as a one-size-fits-all or a perfect test. And the same goes to the testing method or testing platform, because different methods detect different types of genetic barriers. So for example, if I order a microarray or the ACGH over there, the test won't be able to pick up any small nucleotide level genetic changes. So knowing this sort of information is also extremely important when it comes to interpreting your genetic test report and deciding the appropriate next steps. Then after you receive the results from the lab, obviously you disclose the results back to the patient. But after that also comes post-test genetic counseling, which is essentially navigating patient through their genetic test report and what this means for them as well as their family members. And this is where the pre-test education about genetic concepts play an extremely important role, because I'm pretty sure you can imagine without that, it will be extremely difficult for the patient to understand what's going on at this point. Also, depending on the results, oftentimes we may need to liaise with other doctors or support groups for ongoing clinical management or support. And if the report does confirm an inherited component, we then also need to start thinking about who the at-risk family members are and whether they might need to consider testing themselves. And that's basically what cascade testing on the far right means. So we've talked a bit about what genetic counselors do in clinic, but quite a number of genetic counselors actually do not spend all of their time clinically. So there are many who work part-time or even full-time in other roles such as research. And this is actually becoming more and more of a thing, because many research studies now involve genetic testing, and it is for these research genetic test results to be communicated back to the participants in a safe and professional manner. And some genetic counselors also work alongside testing laboratories in education as well as in policy making. And while the job scopes of each of these might be different, the core role of a genetic counselor remains the same. That is to make sure that the genetic information is accessible and communicated to participants or patients or family members effectively and safely, and that individuals and families affected by a genetic condition are well supported. And the demand for genetic counselors is actually increasing extremely rapidly. So in the US, the growth rate of the profession in the next decade or so is projected to be about 18%, versus an average rate of about 5% across all occupations. And when I tried looking up the numbers, 18% is actually one of the lower estimated growth rates. So many other sources actually predicted the growth rate to be much higher than that. And no talk about genetic testing will be completely showing this graph. So this plot shows the drastic decrease in the cost of sequencing a human genome. Thanks to the advancement in technology, what used to cost over $1 billion is now achievable with a few $100s. And there were also recent articles that suggest it may even go down to below $100 in the not so distant future. But essentially what this means is that genetic testing is becoming more and more affordable and accessible in the grand scheme of things. And I do say that very cautiously because especially for patients in low to middle income countries, a few $100s is still a considerable amount of money. But generally, because of the decreasing cost of genetic testing and the continuous improvement of testing methods, the number of genetic tests that are being ordered have been going up. And while this graph shows what's happening or what was happening in the US from 2014 to 2017, I would assume that the trend is fairly similar globally and to date as well. And this is a quick snapshot of the genetic counseling workforce globally. However, do note that this was data from 2017, and without a doubt, there are more practicing genetic counselors now. But I suppose the proportions across continents would still be fairly similar. And this is basically a breakdown of some of the countries, again, as of 2017. And what I've highlighted here in red, green, and yellow represents whether or not the country has a genetic counselor to population ratio as recommended by the UK Royal College of Physicians. So according to the RCP, the recommended ratio is 6 genetic counselors, or at least 6 genetic counselors per million population. So if we do some quick maths, actually only the US, Canada, Australia, New Zealand, and perhaps the UK in 2022 have achieved that workforce ratio. So for many other countries, including Malaysia, there is still an urgent need for more genetic counselors. Right, so hopefully what I've shared in the last 15-20 minutes or so have piqued some interest in the audience to consider pursuing masters in genetic counseling, which by the way is the minimum requirement or qualification required to practice genetic counseling. And here I've listed down some key things to consider if you do intend to apply. And while I'm enrolled in an Australian program, the selection criteria is actually pretty similar across all programs globally. So the first thing is to demonstrate that you have at least an undergraduate level genetics knowledge, which normally has to be undertaken in the last 5 years or so, just because genetics is such a rapidly evolving field. Having said that, though, it doesn't mean that you need to get into the program within 5 years after your bachelor's. I do know people who have worked for 5 or even 10 or even longer years, but kept up to date with their genetics knowledge by taking online courses and so on. So that's also another way to go around it. And the next thing, which is also pretty much essential, is to have at least 6 months full-time equivalent experience of working in a caring role. And some people get this experience by, say, volunteering for crisis hotlines. Some people work with disability support groups. Some people may help out in special schools. But one thing to note, though, is that while shadowing a genetic counselor does give you valuable insight to the role, most programs actually do not count that towards a caring role experience per se, unless you have some sort of, I guess, direct interaction with patients, which are not very common. So personal statements and references are pretty standard stuff. Now, research experience and basic training in counseling skills are usually not mandatory, but it would be a huge advantage if you have some experience in those, because that will make your life in postgrad training a whole lot easier. And the last thing I want to touch on is about reflective practice and reflective writing. And this is where a lot of science graduates, including myself, struggle with, because in a way, it is the total opposite of what we're used to in scientific writing. So it is essentially getting comfortable with voicing out or writing out your thoughts and feelings towards a particular situation or a particular scenario, be it clinically related or not, and why you feel that way, which is actually an extremely important skill to have as a genetic counselor. So this is a fairly busy slide, but I'd just like to finish off by talking a bit about certification. So depending on which country you do your training in, some countries or some regions have professional bodies that regulate the certification of genetic counselors. So for Australia, that is the Human Genetic Society of Australasia, or HGSA in short. And I'm not going to say anything more about this slide except to say that full HGSA certification is the top. So if you can help me point to the top right. So the second box, yeah, not that one. So the top one, the dark blue one. Yeah, cool, thank you. So that is where full HGSA certification is. And if you can move down all the way to the bottom left, the orange one. So all the way down to the bottom left of the slide, the orange to the left. So if you can see, yes, so that orange box that says something along the lines of Master of Genetic Counselling, I think. So that's where I am currently. So quite a long way to go even after you've done your postgrad training, but I guess understandably so, because at the end of the day, you will be a healthcare provider. And the entire process basically involves things like logbook cases, so short cases, long cases, reflective essays, reports, and so on. And I think some boards, for example, in the US or Canada, also require a genetics knowledge exam. But essentially, you are allowed to practice as an associate genetic counselor after your master's and work your way through your certification while working. And so this is the final slide I have. If you are thinking of pursuing the profession, I would highly recommend having a look at the websites of the respective genetic counseling professional bodies. So again, HGSA is for Australia and New Zealand, ABGC is for the US, GCRB for the UK, CAGC for Canada, Board of Genetic Counselling India, or BGCI for India. And I think there's also one for South Africa as well. And while in most Asian countries, as well as in the Middle East, I think there are currently no local certification pathways for genetic counselors. There are national and regional genetic counseling professional bodies that are working towards that. So for example, the PSGCA or the Genetic Counselling Society of Malaysia, or GCSM. So again, I highly recommend people to have a look at the information that they have on their websites, or get in touch if you want to know a little bit more about the profession in your country or in the region. Yeah, I think that's pretty much it for me. Yep. So hopefully I've left a bit more time for plenty of Q&A and discussions. If you like a copy of the slides or want to ask me anything offline, feel free to drop me a message via LinkedIn or email. And with that, thank you for listening.